Hello, I'm Sue Hughes. I'm a journalist with theheart.org. I'm here today with Dr Sunil Rao from Duke University, and we're going to be discussing the GRAVITAS trial. Dr Rao, would you like to just talk us through the main design and results of the GRAVITAS trial?
Sure, thanks for having me. So GRAVITAS was a really interesting study. It's really the first large study to look at, in a sense, tailored antiplatelet therapy using the point-of-care assay, the Acumetrix Verify Now. So 2,200 patients, largely undergoing elective PCI, who had received a drug-eluting stent, 24 hours after their procedure, underwent testing with the Verify Now Acumetrix device. And if they were felt to be a responder to therapy, that is, remember the Acumetrix device reports platelet function in terms of PRUs. So if they had PRUs at a certain level, they were considered to be responders, and then they were sort of followed. But if they were non-responders, they were then randomized in a double-blind fashion to higher doses of clopidogrel versus usual care. So that would be a 600 milligram loading dose followed by 150 a day versus usual care of 75 a day, and followed out for 6 months for clinical events. So this is really the first, like I said, trial to look at whether or not testing patients and then intervening on the basis of that test using more aggressive platelet inhibition with clopidogrel actually affects clinical outcomes. And the reason I hesitated to say the word tailored, because there was no adjustment made for patients who were hyper responders. So this is really looking at efficacy. They measured safety, certainly, and it was a double-blind trial. And so I think it's a very, very important study because people have been doing this in clinical practice really without a lot of guidance. We believe that greater platelet inhibition improves outcomes. We think that being aggressive with clopidogrel improves outcomes. And this trial really tested that.
Okay, and what did the trial actually show?
So amazingly, and I think this certainly stunned a lot of people, was that the curves were completely overlapping in the randomized arms. There really did not seem to be any benefit of increasing the clopidogrel dose among patients who were defined to be non-responders using the Verify Now test, which is really a terrific result. It's a negative result, but I think it's horribly important to report negative trial results because I think this will impact care. If you're a center that is testing patients using the Verify Now device and then changing what you do by increasing the clopidogrel, this trial says that that strategy does not seem to improve clinical outcomes. Now, certainly there are other questions to be asked. Does this sound is this the death of platelet function testing? I don't think so. And the reason that I don't think it is that remember that we have other strategies now. If this was 10 years ago and we didn't have other platelet agents, like prasugrel, like ticagrelor, that provide even a greater level of platelet inhibition, I think this probably would be the end of platelet function testing. But I think now that we have agents that can provide a more potent effect, that's probably what we need to be testing.
And how big a problem is this variability in clopidogrel response and these non-responders?
It's a terrific question, and I think it really depends on your perspective. If you're talking about purely how many patients are deemed to be non-responders, I think you can get studies that certainly show that it's in the double digits. I mean, Victor Cerebrani showed us very nicely that the response to clopidogrel, purely based on residual platelet reactivity, is a bell-shaped curve. Now, when you're talking about clinical outcomes, the answer becomes a little bit more complicated because what we really have are observational data that demonstrate that whether you're using LTA, which is the gold standard, or you're using Verify Now, that there is an association between high residual platelet reactivity and worse clinical outcomes. The big question, and I think Jessica Mega pointed it out very eloquently in her discussion of the trial, is this a risk marker or is it a modifiable risk factor? And there are trials that are ongoing now to determine the answer to that question. The interesting thing about this trial is that doubling the dose of clopidogrel achieved really just a modest reduction in platelet reactivity, really not that much of a difference, and perhaps that's what drove the results that we saw, which is really no significant difference. The other issue, of course, is that the event rates were very low. This is an elective PCI population. The event rate was somewhere around 2.3%. They were hoping for a 5% event rate, and they were banking on a 50% reduction in events. So given that, the trial really wasn't powered to look at differences when you have an event rate that low.
But I think he said, didn't he, I think Dr. Price, who presented the trial, said that he didn't think that they would have shown any a positive result, even if there was a much bigger trial.
And I agree with that. I think that, and Matt Price said it very, very nicely, which is, if you had a larger trial, would you show a clinically meaningful difference? And that is really the key. We can show statistical differences if we have a very large trial, but the question is it a clinically meaningful difference? When you have an elective PCI population, what we've learned over time is that these patients tend to do very well. It's very difficult to actually show meaningful differences in outcomes in that particular patient population. So I think what we have now is really two groups of patients. We have patients at high risk, which are those who have acute coronary syndromes, and patients who are at substantially lower risk, or so-called the elective PCI population. And perhaps it's the higher risk patients, the ACS patients, that may benefit from more intense platelet inhibition.
So maybe this was the wrong population to study?
Well, I think in retrospect, I think we've shown that. And I think that, I hesitate to use the word wrong population, because GRAVITAS, I think, is a very, very important study. It's a very well done study. The investigators identified an issue, they asked a question, they performed an experiment, and they got an answer. Now we can build on GRAVITAS. And we can say, okay, we need to move this to a different patient population, maybe study a different intervention. And as you know, there are other trials that are ongoing. Trigger PCI, for example, that is looking at a different reactivity cutoff. This trial used 235 or so. Trigger is using 208, substantially lower, using prasugrel, a much more powerful agent. But I think the larger question for clinical practice is, as we have the availability of more predictable, potent agents like prasugrel and ticagrelor, is this something that's going to be of historical significance? If we can get a response in everyone with one agent, maybe we don't need to be testing. And I think that's the real question.
And do you think it might boil down to expense, because clopidogrel will be coming off patent and people might want to use that as their first choice? So is it a matter of just doing one platelet test? But I don't think it's that simple, is it?
Well, I think you're asking one of the most important questions. And this really gets to the intersection of efficacy and effectiveness, which is, how do we use the therapies that we have? Particularly in this country, where we're undergoing such dynamic healthcare reform. As you mentioned, one of the antiplatelet agents will be generic soon. It may not be substantially cheaper, but it certainly will be cheaper. And for large health systems and for patients who are trying to make decisions about which drugs to buy, platelet function testing may be a way to identify those patients who really do require newer agents that are most certainly going to be more expensive. So I think you're hitting on really an important question that hopefully ongoing trials will answer.
And do you think we need to do more than one platelet function test?
That's a terrific question, and I think one thing that's fascinating from the GRAVITAS data is that even in the patients who got the 75 milligram dose of clopidogrel, they also had a reduction in residual platelet reactivity over time. So the drug actually became slightly more effective over time. And we know that platelet reactivity tends to be a dynamic phenomenon, so I think that we probably will need more than one test. The question is, what's the pattern of testing? And I'm not sure that we're sophisticated enough to know that yet.
And in that regard, do you think that genomic testing might be better because you only actually need one test there?
That's a great question as well. And, the story on genetic testing, I think, is fascinating, because I don't think that what we've seen in the last few months with the reporting of the genetic data from Plato, as well as from the CURE and ACTIVE trials combined, suggests to me that maybe there's no role of genetic testing. But we have observational data or post hoc analysis from Triton that shows that maybe we should be testing. So I think we're really at a crossroads here, and I think that for clinical practice, the real issue is that we shouldn't be testing people if we don't know what to do with the results. And I don't think we know what to do with those results yet.
But still, it might be of benefit, surely, to identify the patients that you do have to worry a bit more about, perhaps, on clopidogrel. Maybe. Although remember, in the CURE trial, it didn't make a difference whether you had a loss of function. But they were not interventional patients, were they?
The majority weren't. And that brings up another point, is the timing of when you need that intense platelet inhibition. Remember, in GRAVITAS, they were randomized 24 hours or so after they got the PCI. Perhaps the risk period there is much lower. Maybe we need to be identifying these patients before they go to the interventional lab, where at the time of balloon deployment or stent deployment, that platelet reactivity needs to be really suppressed. So lots of outstanding questions, but I think GRAVITAS is really a terrific study, and the investigators really should be congratulated for doing the trial, reporting the results, because I think we can really build on it.
Okay. And in the study, there was an observational arm as well. Would you like to just tell us a bit about that?
Well, I think we can talk about it in a very general way. I think certainly the the observational data were not the focus of the GRAVITAS presentation, but I think they did something very important, which I think we're trying to do more often in clinical trials, which is to have a concomitant registry. So we can try and compare and contrast the patients who get into trials and those who don't. And I'd like to see that happening much more commonly in trials, because I think it provides really a rich database on which to generate even more hypotheses, and I think that's what the investigators are planning to do.
And the observational arm did show that these patients that don't respond well to the normal dose of clopidogrel did have worse outcomes, I think.
Right. I think probably the right way to say that is to really not imply causality, because what they found was an association between high residual platelet reactivity and worse outcomes. We're still, I think, wondering about this risk marker versus mediator issue with respect to the, again, specifically platelet function testing using the point of care assay.
So you don't think it is a proper risk factor?
No, I think it's a risk factor. The question is it a modifiable risk factor?
Right.
And that's really where we need to figure out whether or not we need to intervene on these patients, and if we do, how we intervene on them.
Thank you very much, Dr. Rao. So that's all from the GRAVITAS trial.